affected scalp as shown, and the posterior non-affected scalp. Histologic examination was completed and was graded moderate to intense, mild, or absent. Samples from both areas were analyzed, and the analyses were done by a dermatopathologist blinded to this study. It was found that 60% of the patients with frontal fibrosing alopecia and 80% of LPP patients had inflammation in normal appearing areas. This has been translated clinically for us to begin looking at treating these patients, not only with systemic agents, but also with overall vigorous treatment of the scalp and maintaining excellent scalp health. So the current perspective for LPP FFA pathogenesis includes all the things shown here: the potential genetic predisposition, environmental xenobiotics, dioxins, whatever you would like to put in that circle, fibrosis, inflammation, increased cytokines, lipid oxidation, sebaceous glands and stem cell impairment, loss of nerve fibers associated with decreased CGRP was found in the study, potentially a protector of the bulge region, and increased substance P. So I'd like to acknowledge for this part of the talk Dr. Isabella Dosch, and below Dr. Valenti and Dr. Ricardo Ramidi at the University of Sao Paulo. So then out of this, you have all this data, what are you going to do with it? So one of the things that we did is to think about topical gabapentin and to target these neuropathic changes. And so gabapentin was introduced in 1994, quite some time ago, for the treatment of epilepsy. It is used to relieve pain, especially neuropathic pain syndromes associated with diabetes, vulvodynia, postherpetic neuralgia, and other allodynias. In the clinical study that was done, we recognized that we don't know how gabapentin really works. It's thought to work through voltage-gated calcium ion channels, and its neuromodulatory effects could also impact the peripheral nervous system. This is the study formulation that was used and compounded in the pharmacy, and with that, what patients did is they applied the solution for 2 weeks, and at each visit, they answered questions about itch and pain, and we did the lichen planopilaris activity index. And with that index, for those of you who have used it, the first 3 questions relate to the patient's subjective assessment of pain, burning, and itch. And then following that, one examines the scalp for generalized erythema, perifollicular erythema, perifollicular scale, as well as spreading and crusting. And there's a score that's attained that you can monitor clinically. Serum gabapentin levels were also monitored. What was found after treatment was an increase in average epidermal nerve fiber density, an increase in one of the neuropeptides called VIP, and no difference in CGRP or substance P levels. This is a picture of the results from one patient, where on the left you see the pre-treatment biopsy with very few epidermal nerve fibers, and on your right you can see the presence of those green nerves entering the epidermis, crossing the basement membrane. The patient also had a reduction in clinical activity and symptoms as evidenced by decreasing the LPP-AI, as on your right, the visual analog scale for itch, and also pain scores. And then most interestingly, we noted that hair growth was present at the end of this 12-week trial. So we now use this tool as another tool in our armamentarium of trying to treat complex patients who have severe pain or itch with one of these cicatricial alopecias. So in summary for this part, the biopsy showed very few epidermal scalp nerves consistent with small fiber neuropathy. An increased number of scalp nerves after treatment suggests that topical gabapentin could help improve reinnervation. This patient had regrowth. The drug was well tolerated and not absorbed systemically. The clearly more patients need to be studied. Then there's the frontal fibrosing alopecia and what happens to the forehead region of patients affected with this disease, as well as the papules that form on the cheeks and the loss of the hair of the eyebrows. So Dr. Donati, at that time at the University of Sao Paulo, published in JAMA Dermatology how those papules reflected and showed a lichenoid infiltrate. The forehead has been very challenging for people because we all don't know, is it a change in the collagen? Is it a change in the vasculature? So we began to use non-invasive techniques to look at forehead dimensions, skin thickness and density, epidermal water loss, and the way the C fibers function using current perception thresholds. And this is what I'm talking about. You see the line of demarcation where the forehead used to be, how it has regressed, and here you see it on the sides where the veins begin to become very prominent in their appearance. And this is very bothersome to many women. And in our clinic, we will use retinoids at this time to try to change the collagen. We have not advanced to using hyaluronic acid or other fillers because we really still don't understand what is going on in this particular region of the forehead. And here are some of the study participants, and you all recognize these patients. They have that very prominent V in the middle of the forehead, and when you look from the side, the veins are also very, very prominent. So in that group of patients that were studied, one measured the dimensions of that regression and also skin thickness and density using ultrasound techniques, transepidermal water loss, and what was found is that on average in this population, almost 3.5 centimeters of frontal hairline recession was present, and that patients had less transepidermal water loss, a thinner but more dense epidermis, and lower nerve function thresholds. But what does that all mean clinically yet? We don't know. As far as the pigment cell is concerned, if you examine these patients with a black light, one will see that there's like a vitiligo appearance to the skin of many of these patients as well. There are studies that have been done and are being done, and one the British have published that they believe the frontal fibrosing alopecia is related to the use of sunscreens. In the US, there is a multi-center study that is under the guidance of Dr. Olson from Duke University, and close to 300 people have finished extensive questionnaires to try to figure out where to best focus one's attention in this disease that in 1994 was present in one publication with 4 patients, and then in the past couple of years has surged in its incidence as well as prevalence. So here we are, we have a complex group of diseases, not many people study them, the patients are difficult, can be, they don't have to be, difficult to manage, and so some progress needs to be made. So this May, at the Society for Investigative Dermatology meeting, there was a research foundation meeting, and I'd just like to share with you the direction where this group of complex diseases is going. Some speakers felt that in contrast to alopecia areata, there really wasn't any sort of genetic basis. But others said, well, maybe there is, at least for some forms. And then those who like mouse models found that mapping mouse transcriptome data to the human genome, the candidate genetic intervals for susceptibility to keratosis follicularis spinulosa decalvans, a rare form of cicatricial alopecia, showed a duplication in chromosome 21. And this was associated with putrescine accumulation, a mouse model reminiscent, therefore, to human KFSD exists for those who work with mice and mouse models to try to figure out this disease. There does, however, appear to be a familial preponderance with central centrifugal cicatricial alopecia. So then there was this question about diagnostic overlap. So are these diseases distinct? Are they not distinct? Are they just rather clinical presentations that differ in a spectrum of disease derived from the same mechanism? That's cirrhosis that was referred to earlier, where you can look under the microscope and all the patients clinically are different, but under the microscope they all look the same. Is there one common pathway? But then there was a publication where lichen planopilaris could be differentiated from pseudopelanobrach by transcriptome analyses, where MMP11, TNFSF13B, and APOL2 were identified with significantly differential expression separating these two diseases. So there is the potential for biomarkers to be used to separate out this complex group of cicatricial alopecias. And then there's the sebaceous gland. There are those who firmly believe the sebaceous gland is the culprit in this group of diseases, and that's where the problem lies. So RNA-seq-based transcriptome analyses have been performed on sebaceous gland, isolated from biopsies. And when compared to sebaceous glands from the scalp of age and sex-matched controls, there was a distinct RNA expression. 357 genes were expressed, and sebaceous glands from LPP had downregulation of the lipase H gene, which is important in the normal growth of hair. So these results suggest that certain sebaceous gland-derived lipid mediator genes could be altered in LPP. So in summary, the future goals for this complex group of diseases will be for us as clinicians to successfully treat our patients with the tools that we have, and don't forget light, because it may be helpful in managing the inflammatory component. Use the tools there to try to recover some hair growth once the disease is quiet. And for the future, one will begin to look at adequate numbers of good biopsy samples for RNA-seq transcriptomics, shotgun lipidomics, and shotgun proteomics, things that most of us as clinicians don't routinely do, but this is where the work needs to go. With that, there has to be access to these computational analyses, these software and expert biologists who use this to look at those immune infiltrate signals and predict potential therapeutic candidates. And then probably most interestingly is that the bacteria, viruses, and fungi that inhabit the skin and gut can have profound effects on the development and progression of skin diseases. And microbiome studies need to be included in the future of studies of the primary cicatricial alopecias. And while the research goes in that direction for your patients, there is an organization called the Cicatricial Alopecia Research Foundation. It provides information for patients and is accessible at this website. Gracias.